Good morning, everyone, and welcome to the May 5th Safe and Calm webinar. This is Deanna Mitchell from Leading Age Michigan. Today we have a slightly abbreviated agenda that will focus on the updated CDC guidance that was released last week. That guidance covers small updates to visitation, testing, and travel based on vaccination status. We want to note up front that while these slightly more flexible guidelines have been issued by the CDC, we have yet to hear from MDHHS about these changes, although the travel guidance has not really essentially changed and remains intact. And although the department has been more in line with the CDC lately, we can't be sure how they will interpret these changes specifically for Michigan. And Dalton is not here this morning, but we will be covering the updated FAQs for the HFA and AFC wage increases briefly. They continue to look complicated, and we will go through those as best we can. And we will follow up with updates from MDHHS on reporting for both nursing homes and HFAs and AFCs. So let's get started with a brief situation update. As you can see from the CDC graphs here, although caseload is easing in Michigan, Michigan is still at the top of the list in terms of new cases per 100,000 people. What is a bit disconcerting is that even with the level of vaccination across the nation, you can see that more states this past week have turned darker shades of blue, and that means that caseloads are going up. And again, although easing in Michigan and cases are going down, we still have a lot of new cases each day. Here is our updated graphic for the Michigan 7-day average caseload in Michigan. We peaked again in mid-April, as you can see, and we're now beginning to come back down, thankfully. And we'll have to see if the governor's somewhat relaxed mask requirements have any impact as we move forward in the next couple of weeks. Changes in the trajectory of death rate, they usually follow the caseload trends, although they lag. We didn't have the same peak level in April that we saw in December. And they seem to have stabilized, but they have yet to start falling downward following the caseload changes. We do note that many of the recent deaths include fewer very old persons and much more middle-aged persons, actually. Here is the updated graphic showing the trends in the CMS county positivity rates for Michigan. As of this past Monday, you can see that the county rates have continued to remain pretty stable, with the large majority of counties with rates greater than 10% still in Michigan. Looking specifically at the long-term care data, we have seen a very slight increase in new resident cases in nursing homes over the past month or so. But it seems to be somewhat stable with most residents currently vaccinated. When we look at the CDC data, and this is data that is directly from Michigan from NHSN, you can see that the graphic for new cases per 1,000 resident weeks has a similar shape for nursing homes as we just saw. And remember that this slide is specific to Michigan, but we do see these small inclines. So we're going to have to watch this closely as facilities work to keep new residents vaccinated. This graphic, also from the CDC, looks at the weekly cases among staff in nursing homes. And you can see a much larger increase in recent weeks. And again, this is for Michigan specifically. This is somewhat of a concern considering the staffing issues that are very challenging at this time. And when we review the updated CDC guidance, which we will do shortly, we were thinking that the fact that vaccinated staff in general will not have to undergo serial testing might be an incentive, as long, of course, as MDHHS comes out in support of that. For Michigan HFAs, the weekly caseload is pretty stable for residents, although, again, very slightly increasing over time, and we're not sure yet whether or not that's a trend. The same is generally true for AFCs as well. The number of new cases have been going up a bit, up and down a bit overall. We do see slight inclines in that trend in caseload that might bear watching. Looking at all the Michigan numbers in terms of long-term care as of Monday, we're now over the 45,000 cumulative caseload mark with new staff cases still as high as 345 across all the setting types for the past week. The date says 426 up there, but that's an error. It really is 5-3. Whenever we look at the vaccination numbers, every site that we look at, it quotes slightly different numbers for Michigan. So we're going to try and be consistent and use the CDC numbers. So across the nation, 40.6% of all persons over the age of 18 have been fully vaccinated. And that percentage increases to 69.7% for persons over age 65. In Michigan, about half of all adults have been vaccinated. So we continue to work on getting more and more people vaccinated here in Michigan. So we're going to move on now to the CDC updates, and we're going to focus on changes to visitation and testing. But we are going to start with a few CDC updates that are actually good resources for long-term care facilities. And there are links to several here. Vaccination communication tools for staff and residents, frequently asked questions about COVID vaccination. These were all updated late last week. On Thursday, they also updated the interim public health recommendations for fully vaccinated persons. Again, the CDC continues to remind everyone that these do not apply to immunocompromised persons. But in general, fully vaccinated workers no longer need to be restricted from work following an exposure as long as they are asymptomatic. Fully vaccinated residents also do not have to be quarantined following exposure as long as they don't reside in a healthcare facility. But residents in nursing homes, AFCs, and HFAs will have to continue to be quarantined if they are exposed. And fully vaccinated asymptomatic persons may be exempted from serial testing, and that is an important piece moving forward. Last week, the CDC also issued an updated infection prevention and control recommendation. And this specifically takes vaccination status into consideration. This first part on this slide is basically unchanged. It still is recommended that if unvaccinated, for an unvaccinated person, indoor visitation should be prohibited if the county positivity rate is over 10% and less than 70% of residents are vaccinated. So you must remember that both these issues must be true to restrict visitation to unvaccinated persons. Compassionate care is allowed for persons under quarantine or isolation. And again, these rules have not been updated, but QSO 2039NH has again been updated to reflect some of the other changes, which we'll discuss next. In general, all the same overall operational requirements apply to ensure safe visitations. Visitors have to be screened, and their vaccination status will matter. However, no one, either CMS or CDC, expects facilities to verify a visitor's vaccination status. Their response to a simple question will suffice. Visitors must continue to wear a mask when in the facility, with a few exceptions, and must continue to distance themselves. Visits should ideally take place in a single room. If residents are sharing a room and the resident to be visited is unable to leave the room, if the other resident is unvaccinated, they should not be present. They should not be present if possible at all. And if neither are able to leave the room, everyone should be wearing masks and continue physical distancing if there is any time where someone in the room is not vaccinated. Facilities should attempt to keep designated areas with only one visitation group at a time, or everyone in the room must wear source control regardless of their vaccination status. When both the resident and all of their visitors are fully vaccinated, if they're alone in a room, whether or not it's a private room or a designated area, they can choose to have close contact, including touch, without wearing masks. But visitors must wear masks and distance themselves when they move throughout the facility. If anyone in the visit group is not fully vaccinated, everyone must wear a mask and physically distance themselves. But the resident, if they are vaccinated, they can choose to have close contact, including touch, as long as all parties are masked. Regarding communal activities, obviously anyone in isolation or quarantine, whether they've been vaccinated or not, cannot participate in any group or communal activities. Facilities, when planning or organizing a group activity, if anyone in the group has not been vaccinated, or if someone's vaccination status is unknown, all must wear source control and physically distance themselves. But when residents in an activity are all fully vaccinated, they can choose to have close contact and not wear source control. So this provides an awful lot of flexibility in what people, residents can do together if they're all vaccinated in groups in our facilities. But anytime there is any unvaccinated person present, again, everyone must go back and take full precautions. In terms of dining, fully vaccinated persons can dine together without source control or distancing. But again, if anyone is not vaccinated in the group or in the room, source control is required when not eating, and physical distancing is needed. CMS has let us know that they are allowing cohorting in activities based on vaccination status. In other words, if you have different lunch times, you can put all the vaccinated people together in one group to allow them a little bit more freedom. Leading Age is concerned that there could be some resident rights issues about that, and so that's something to think about. But CMS is allowing facilities to cohort these activities. In terms of staff, even if vaccinated, all staff must continue to wear masks while working. Although they can dine and socialize in break rooms or hold meetings without masks and distancing, as long as everyone in the room are all vaccinated. Fully vaccinated staff with high-risk exposures need not be restricted from work anymore. Staff must continue to follow the travel recommendations on return, and we're going to review that guidance shortly. Fully vaccinated residents do have to continue to be quarantined following close contact. So as usual, there are different rules for residents from staff. The CDC does say that facilities can circumvent this if staffing is an issue. but we're not sure that MDHHS is going to allow that. And although this part, although recently updated, it has not been changed in the most recent current guidance. New admissions who have been vaccinated do not need to be placed in quarantine as long as they have not had a prolonged close contact in the past 14 days. Testing. Testing is obviously still required for anyone who develops COVID-like symptoms, regardless of whether you've been vaccinated or not. But any asymptomatic staff or resident who has been exposed, whether vaccinated or not, should have at least a series of 2 viral tests immediately and at 5 to 7 days following exposure. And of course, you're going to go into outbreak status at the same time there. Recovering persons obviously are exempt from testing following exposures as long as they are asymptomatic. Outbreak rules, again, still apply. All staff and residents, regardless of vaccination status, should be tested every 3 to 7 days until 14 days elapse with no new cases. Again, fully vaccinated staff do not have to undergo serial testing, and this is what we're waiting to hear from MDHHS, as long as they're not symptomatic, as long as they've not had an exposure, and the facility is not in outbreak status. Unvaccinated staff have to continue the regular CMS and MDHHS requirements for testing. Pre-admission testing. The CDC says that pre-admission testing is at the discretion of the facility, but remember that it is still required within 72 hours by MDHHS at this point. So let's take a moment and pause for any questions about these CDC updates.
All right, thank you very much, Deanna. We do have a few questions, so I'm just going to go right into those. Are we still required to COVID test all staff weekly in assisted living, vaccinated or not?
Well, right now, yes, you do. The CDC does not require serial testing for vaccinated persons, but we've not heard from MDHHS. So we need to wait for that, and hopefully that will not take a long time. So it could change shortly, but we're waiting for confirmation from the department.
Do you know when MDHHS may give guidance to follow the CDC recommendations? They told us to continue as we have been doing last week.
Right, and you still must continue to do that. And no, we've not heard any dates or target times that they're going to come out with updated guidance. And to be honest with you, they're very, very hard to anticipate. So we do hope that they do come up with something soon, but we don't know. We don't have an idea of when that would be.
I think it's kind of a repeat question, but do you know when MDHHS may give guidance to follow up or follow the updated QSO as well?
The same thing. The updated QSO, it really only includes minor changes as reflected in the CDC guidance here. But again, no, we don't know.
Okay. If a visitor was vaccinated and asymptomatic and was visiting for 1 hour in LTC and was positive during the visit, is this considered an outbreak? Found out the testing result after the visit. Testing was for surgery.
There's not clear guidance about that, but I would think that that would have to be considered an outbreak if they would have tested positive near the time that they made a visit. I think that the prudent thing to do would be to consider that an outbreak. But remember that you can apply the new CMS guidance for that QSO 2039 quickly and immediately test everybody in the facility, and then based on the contact area, the affected area where that person would have been, if indeed you would only have to quarantine that area if the rest of the facility doesn't test positive. So I would consider that an outbreak because we all know that it is possible. The vaccine is not 100% effective. It is very, very effective, but not 100%. And so if you don't treat that as an outbreak, you would be putting residents potentially at risk.
Okay. Do the CDC guidelines only apply to nursing facilities?
No, they do not. The guidance is really meant for all long-term care facilities, including the travel guidance. It is not specific to nursing homes, although it's often written that way. And again, we'll have to wait to see what MDHHS's take on that. But we anticipate that MDHHS will apply all of the same rules to all three settings for most matters.
Okay. So once confirmed with MDHHS, is this saying fully vaccinated staff in a SNF do not need to be tested weekly or twice weekly?
That's true. If once confirmed by MDHHS, and I think that that's a very positive thing for staff, and actually might be a great incentive to get some of your staff more vaccinated. They do have to be vaccinated. Unvaccinated people will still have to be tested based on the schedule for both MDHHS and CMS, but vaccinated persons will not. But again, we have to wait to hear from the state.
Okay. Can residents who are fully vaccinated use the same materials and activities such as sharing dice or working on a puzzle together, etc.?
Yes, if everyone in the group in the room is fully vaccinated, yes, they can touch, they can have contact, they don't have to wear masks, they do not have to physical distance. So if you think about it, that allows them to engage much better. And so hopefully this will be a positive thing. Again, waiting for confirmation from the state.
Can we follow the CMS directives about visitors and residents not wearing a mask during their visit if both are vaccinated?
I don't think you can do that until we get confirmation from the state. I would anticipate that the state is hopefully going to follow the CDC guidance here, but you do have to wait for confirmation from the state. But once that's done, yes.
Okay. Can a visitor who is fully vaccinated eat a meal with a resident who is fully vaccinated? The visitor comes in for compassionate care to help feed the resident, and she believes he will eat better if she is also eating.
Yes, there's no, based on the new guidance and subject to support from MDHHS, I have to put that disclaimer out there. Yes, you know, two fully vaccinated people, visitor, resident, resident, they can have contact. And so, yes, sharing a meal will work and be part of that because you don't have to physically distance. You don't have to be concerned about ventilation and eating. So yes, but again, you have to wait for MDHHS to confirm they're going to follow the CDC guidance.
Okay. Are volunteers allowed if tested with staff?
That's a good question. The most recent guidance, I really think that the guidance about volunteers have not been 100% clear over time. And the most recent thing that I've noted from the state, the CDC doesn't really weigh in a whole lot here, is that volunteers were really allowed pretty much for specific reasons. But I would think that if they're vaccinated I'm sorry, repeat the question. Is this about testing or vaccination?
All it says is, are volunteers allowed if tested with staff?
I would think at this point that considering the visitation rules are open, that volunteers would be included in the ability to move in as long as they're tested at the same cadence as other staff. But let's confirm that with the state. They haven't been very detailed in the use of volunteers. And the last requirement that I saw really still limits them into what their capacity is. So let's find out a little bit more from the state about the status of volunteers.
If all residents in an activity are vaccinated, but the staff who is facilitating the activity is not vaccinated, do all of the residents then have to wear a mask and social distance?
Yes. If anyone in the room is not vaccinated, then you go back to the old rules.
Okay. Leading Age put out material saying that nursing homes are permitted to cohort activities and dining according to vaccination status. If choosing to do so, the nursing home must continue to comply with resident rights requirements. Is this recommended, as it seems like this could create other legal concerns?
Well, as I'm fully aware of the leading age guidance, and in fact considered it as it came out. So when you look at resident rights, I think you have to look at some particular issues about access to activities. But still, the COVID rules apply here. So if someone is not vaccinated, they don't have, there are safeguards, there are mandated safeguards that have to be applied. So I think that you could have a problem if someone wants to eat or do an activity with someone else. And I think I would look at that on a case-by-case basis. However, if you have a group of people who want to dine together or do an activity together who are all fully vaccinated, I don't see that there would be a problem with that. Now, there could be some legal issues, and of course, you know, you can always consult your lawyers, but I would think that it provides allowing fully vaccinated residents to group together on their own, gives them a degree of engagement that they have not had to date. So I wouldn't want to preclude that either. I would look at everything on a case-by-case basis, decide if you have any legal risk before moving forward. But my personal feeling is that this is an opportunity for some of your residents to better engage.
Has anything more been said if we still need to hold deliveries for 24 hours prior to giving them to the residents?
I have not seen or looked at any requirements for that in a very long time, so I'll have to defer that question and we'll look into it. The reality is that the virus is almost never spread that way, so I would think that there'd be very, very little risk, but we'll try and find out, see if there's any updates about that.
Is there still a limit on the number of people who are vaccinated who can be in the same room together?
Not that I'm aware of. The governor, we know, just updated some of her guidance, but that doesn't apply to nursing homes or long-term care facilities at all. I have not seen anything in the CMS or the CDC guidance at all about the number of vaccinated people that can gather. The number of people who can gather who include unvaccinated persons, of course, would be limited to social distancing. And so, but I don't see anything there that's a problem as long as everyone in the room is vaccinated, including your staff.
We can't yet cohort vaccinated residents without masks, correct? MDHHS has to update this too.
That's correct.
Okay. Despite CDC, we are still restricted by the MDHHS rules, correct?
Correct.
All right. It looks like those were the last two questions, so we can go ahead and move forward.
Okay. So I don't know about you all, but the travel recommendations, they've been confusing and painful, actually, especially with all the communications between the past month or so that they've been updated by the CDC. So these recommendations have really not changed in any significant way with this last iteration. And it does appear that the department is requiring these rules for staff travel in nursing facilities as written. The CDC first does not recommend any international travel for an unvaccinated person at all. But for any travel, either domestic or international, travelers should review any transportation or destination requirements. People who are traveling internationally, they could be denied re-entry into the U.S. if they don't adhere to some of the requirements. Also, persons must mask when in any type of public transportation, and they are recommended to avoid crowds and social distance as needed. And there's also a reminder to perform hand hygiene frequently. So specific to international travel, all must get tested before returning to the U.S., regardless of vaccination status. And in fact, all air passengers must have a negative test no more than 3 days before returning, or they have to have documentation that they are within the recovery period. Otherwise, they might be denied re-entry into the U.S. They also must get tested within 3 to 5 days of return and self-monitor for any symptoms. If they're unvaccinated, they also have to quarantine for a full 7 days after travel, even if tested negative. And if they haven't tested at all, that quarantine time increases for 10 days. And this is the sticky part here. All unvaccinated persons who have engaged with high-risk persons, such as a nursing home resident, are expected to quarantine for 14 days if they've traveled and if they're unvaccinated. And that's a big challenge, we know. For domestic travel, and the CDC has no definition for domestic travel. We conversed with them about that. Any movement, supposedly, we would consider it any overnight movement within the United States. Vaccinated persons are not required to quarantine or test unless they become symptomatic. Unvaccinated persons, though, should get tested 3 to 5 days after the return from domestic travel. And again, self-quarantine for 7 days, again, increasing to 10 days if testing is not done. And the same avoidance for high-risk persons is expected for 14 days if you're not vaccinated. And yes, the state considers this a requirement for long-term care facility staff, painful as that is. So those are basically the rules for the travel guidance, and I know that it's painful. So let's, I put another question piece in here because I anticipated that there might be some discussion about this.
Okay, thank you, Deanna. Before we get into any questions, we did just want to let everybody know that we do have a couple programs coming up in the next week or so. So if you are interested, you can head over to leadingagemi.org and you can click on the events tab. You will see that we have our Assisted Living Conference, formerly known as our ALHFA Day, and that is coming up tomorrow at 9 a.m. So you can go ahead and register for that. We also have Finance and Strategy Day coming up next Thursday, May 13th, and registration is open for that. And we should also be putting more programs up shortly, so just keep an eye on that events calendar, check back there, and you should see some more programs coming up soon. With that, we do have a couple questions, so I will get into those. Is a vaccinated resident considered a high-risk person?
Yes, any nursing home resident is considered a high-risk person.
Okay. I have staff that live in Ohio. How does the travel restrictions impact this?
I would not consider that travel if someone is just simply crossing a border to go to work. Borders to some degree are arbitrary. They don't have any meaning other than the fact that they're a state line. If someone's just simply going to work, I would not consider that travel.
Okay. For domestic travel, can our policy say we use a risk-based approach so that we can allow unvaccinated staff back to work after 7 days?
Well, there are several issues with this whole thing. And one of them is that many of you, in fact, sometimes I think most of you are significantly challenged in terms of staffing. And so it's possible to go to some staff mitigation strategies in order to address this. And it might be a way to also encourage vaccination among your staff. I do know that there are some facilities that actually test staff, allow them to come back as long as there's not been any exposures, etc., and test them every day for 14 days. Now, I don't know that that's really sanctioned very well, but I do know that that's something that some facilities have been doing. So I would think that you have to look at every situation individually. If you go to some staff mitigation strategies, you have to document it very clearly and look at the relative risk. So I do think that that is an option, but then you really have to look at the risk and a whole lot of factors in your community. I would be looking at the number of residents you have vaccinated. I'd be looking at where the staff person might have traveled to, and things like that, and your community transmission rates as well. So if you deviate from this CDC guidance, you're going to have really good rationale for doing so.
Okay. Previously, you mentioned immediate testing after travel. What is the purpose of immediate if it takes 3 to 5 days for the positive to show?
I'm sorry, I don't remember saying that. I may have. If someone's symptomatic, of course, they need to be tested immediately. But you're correct. It's 3 to 5 days after returning from travel. I may have misspoken.
Does the 14-day work restrictions apply to AL?
Yes. All of these requirements apply to HFAs, AFCs, assisted living, and nursing homes as they're written right now, dependent, of course, on what the state says. And the state, to date, has applied these travel restrictions to Michigan.
Is domestic travel considered out of state or any travel even within the same state?
I could not get CDC to confirm this, but I get a sense that they mean any travel overnight. So if you go from here to the upper, that would be domestic travel. If you go to Petoskey, I would think that would be domestic travel.
Can I follow the local health department recommendations for returning to work after travel?
Well, I would think that there'd be a lot of support for you to do that. I would assume that if you're wanting to follow the local health department, they must be different than the state. To be honest with you, we have been very concerned about the inconsistency among the local health departments. Sometimes they're more flexible, sometimes they're more stringent, and it's been problematic. But I would say 9 times out of 10, when we've had this discussion with the state will go back to its own guidance and not the local health department, unless there's something going on in that area that requires more restrictions. So I would be leery if the local health department is telling you that you can be more flexible than the state can. And I would probably try to confirm that with the state. And if you shoot me an email, I can try and help you do that.
Okay. Maybe your comments was not immediate after travel, but after exposure. Either way, it seems immediate is fruitless, and we should wait 3 to 5 days.
Let me go back and look at that. I understand what you're saying. I do think that if someone is exposed, I think it's immediate and 5 to 7 days. That's my understanding. If there's been an exposure, I believe it's immediate in 5 to 7 days, as written, but I will confirm that in the Q&A.
All right, it looks like that was the last question for now, so we can go ahead and move on.
Okay. So this next slide isn't really that pertinent to long-term care, but I thought I'd just go over it really quickly because MDHHS continues to update and loosen a lot of the restrictions in Michigan. So yesterday they updated the mask requirements, and these new requirements are effective tomorrow through the end of May. Masks are generally not needed outdoors unless in a gathering of 100 or more. Even though the weather is probably not quite yet, this could affect maybe what some of the facilities can do in terms of outdoor activities as the weather warms. So fully vaccinated persons do not need to mask during residential gatherings at all. So if you're having a private group in your home and everyone's fully vaccinated, you're not supposed to mask anymore. Organized sports no longer requires any testing as long as everyone is asymptomatic. Masks, though, are still required for any contact sport. Outdoor events, greater than 1,000 persons are allowed if they're consistent with MDHHS has this big, large event guidance that they have put out. Any residential outdoor gatherings are allowed up to 50 persons in general. And if there are no more than 20 persons per 100 square feet, I don't know how you'd measure that, but it can go up to 300 persons. So the state is continuing to relax a lot of the requirements for activities. On Friday, Laura updated its frequently asked questions for wage pass-throughs that affect staff in HFAs and AFCs in order to qualify. Some of this is a little complicated, and it just came out on Friday, so we're working through it still. So if you have questions, I may be able to answer them. Otherwise, I'm not sure about a couple of the provisions here. We do know that licensed facilities must be receiving the Medicaid personal care supplement payment for at least one resident in the facility for each month that they're claiming reimbursement. So you should be having documentation to support that you had one Medicaid resident in your facility at that time. So it can't be someone who's simply on Medicaid. It has to be someone that you're receiving Medicaid funds for. Licensed facilities who receive some funds through the Medicaid personal care supplement and that's the Adult Home Help Program. And if they receive some funding through other state programs, such as My Choice or My Health Link, they will receive the increase by submitting a request for all direct staff who qualify, and that request document is out there. MDHHS will be verifying the presence of Medicaid residents in your facility. So they will have to be making payments for a resident somehow in your facility. So it's important that you submit your request on a timely basis, because they're going to go back and look at that time. Anyone getting payment only through My Health Link should contact the department for assistance. Licensed facilities receiving some reimbursement other than personal care supplements through Medicaid. So if you're getting Medicaid funds through other ways as well, you will continue to receive the increase through those programs, but only for services that are authorized and provided by those programs. This is the part that I think is very complicated, and we've not had a chance yet to discuss it with the state. We're going to be looking into this piece. If any member has more information about this element, please let us know. It does seem like this is an extremely complicated program at this point. So remember that the increase applies only to staff who are employed by the facility, no contract staff. And they also have to be providing direct care or supervised care. And only during hours they are awake during their shift and providing care. Now, the way this was written, I wasn't sure if the staff person had to be awake or the resident had to be awake, but I actually think they mean the resident. Administrative staff may qualify for the increase, but only if they're providing direct care or supervised personal care, and only for the hours that they actually do that work. So this is another area that you're going to have to track and document that if you want to provide that increase to people doing direct care, but not usually in that job category. So again, any staff person who's doing personal care, direct personal care, and meet the other requirements such as being awake and working, they're eligible as long as there's one Medicaid resident receiving the personal care supplement. So the supplement is not just for care for the Medicaid resident, it's for all of your residents who are receiving personal care directly, again, during the waking hours. You also don't need to have a COVID case in-house to receive the increase. Personal time, sick time, they're not eligible for the increase. Overtime is paid at the regular increased rate, is not paid at an enhanced rate. There are other exclusions, retirement contributions, worker comp costs, any administrative costs, none of those are going to be reimbursed. Reimbursement is actually through the SIGMA system, which is how Medicaid is paid generally, or pays providers. And information about enrolling is here. You, of course, have to have very clear documentation of how payments are made. You could be audited later. Facilities can choose to provide a lump sum payment and submit one reimbursement form to MDHHS. But in order to do that, you need to let the state know first, and you can use the email address that's on the previous slide to do that. And remember that if you do this lump sum payment thing, you still have to go back and ensure that you have at least one Medicaid reimbursed resident during each month claim. You're not supposed to submit payment requests until you've provided the increase. And it does seem to us that this is very complicated. Oh, this is the reimbursement piece. You can move on. So last week, the HFA and AFC reporting requirements were also updated, not very significantly. In general, they've extended the reporting times from 7 a.m. to 3 p.m. on Wednesdays. But this is only for HFAs and AFCs for some reason. And there's now a data validation process by MDHHS. So facilities that provide data that doesn't look very coherent, they'll likely hear from the department. The reporting guideline link is on the slide page. And remember that that link is only for the reporting rules for AFCs and HFA. And on April 29th, the department also provided an update for nursing home reporting. Effective May 26th, nursing facilities have to start reporting antigen tests through NHSN. And MDHHS will continue to report that data directly through EM Resource. But it also has not changed that if the facility is directly reporting to the CDC through NHSN, they still have to go back and report to EM Resource. There is an EM Resource NHSN module quick guide to assist. I forgot to put the link on this page, but we can get it to you if you don't know where it is. MDHHS, again, is going to be validating the data and looking at it for coherence. They will contact a facility if there appears to be a problem, and they give you till Friday to make any corrections. If no corrections are made by Friday, they're going to submit that data to the CDC as is. And in addition to all of this, we are hearing that NHSN is planning more changes in the near future, just to complicate things more. Questions and issues can be directed to the email address that's on the page. So that ends our content for today. Do we have any final questions?
All right, thank you, Deanna. We do have a few. Even though masks are not required outdoors, MDHHS still requires 6-foot distancing, correct?
I'm not sure about that. I would think so. I don't remember it specifically being included there. And I would, if you're talking about just walking outdoors, etc., I would think that the social distancing would still be required. And I think it would depend on whether or not this is an event or if you're just walking around outdoors. But yes, I would think so. Especially if you don't know who you're coming into contact with.
What is recommendation for identifying staff or residents who are not vaccinated to avoid HIPAA or stigmatization?
Well, you do have to be careful with that, and you do have to make sure that as much as you can, that you keep information private, but you are expected at the same time to track staff and residents and also ask visitors if they're vaccinated. So I think that there's some leeway here. Obviously, CMS is going to allow you to cohort vaccinated people. So I don't think that there's a lot of HIPAA risk here. I suppose that remains to be seen. And then again, leading age has some resident rights concerns as well. So it could be a little sticky, but it appears that CMS and CDC are in alignment with not only cohorting, but allowing vaccinated persons a higher degree of engagement than others.
Does having PACE participants count for the Medicaid requirement for the direct care workers' wage increase?
I know we had that question last week, and that's really Dalton's piece, and unfortunately he's not here today. So I will have to defer that to him because I don't remember what the answer was.
Okay. We have been informed that our AFCs licensed for 12 and under must report positive antigen tests conducted on staff and residents. However, the reporting site says 13 and up only.
Let me look into that. You are required for any facility type doing a test to report positive tests, and I actually think maybe negative tests as well, to at least the local health department in some matter. Whether or not you're supposed to report through the normal HFA AFC greater than 13 bed group, I'm not sure of that. That's something that I would have to confirm with the state. I've not heard anything about this either way until today.
She just said local health department told us we have to report to MDHHS, not them.
Oh, okay. Well.
And she said she'll send you their email.
Yeah, great.
Okay. Please clarify the reporting. We are already reporting POC results into NHSN separately. Is there something new that goes along with it?
Well, I've never been an expert on the details of reporting because I don't do it myself, and I don't understand the system because, again, we don't do it. But my understanding is that you can now do that through EM Resource. That's what I believe the intention of that update is, if that's not the case. But I think that EM Resource now will transfer your POC testing information directly to NHSN.
Okay. MDHHS Section 2D, as a condition of hosting a gathering under this order, organizers must design the gathering to encourage and maintain physical distancing and must ensure persons not part of the same group maintain 6 feet distance.
Right. I didn't remember reading that, but that's what I would have anticipated.
Vaccinated residents are able to gather without limit of person in a group outside or inside. Is this correct?
Yes. If MDHHS approves.
All right. At this time, oh, never mind, we just had one. On our board call with MDHHS leadership, we had confirmation that PACE persons do meet the qualifications for the hazard pay for direct care workers.
Great. I would anticipate that they would have, but I'm not sure of the documentation about that. But I do know that Dalton is aware of it.
NHSN requires an ethnicity be reported, but does not have other or choose not to designate and cannot submit without an ethnicity. How do we code this?
I cannot answer that. I don't know the nuances of the NHSN system since again, we don't use it. However, we can submit a question to the CDC through NHSN if that would help.
The reporting info was confusing, so I reached out about the reporting, and EM Resource does not flow over for the specific POC testing, and it must be submitted separately. It flows for some things, but not the POC tests. I will send Deanna the email from MDHHS.
Thank you. I appreciate that.
Okay. Here's an add-on as well. You have to have level 3 access to SAMS/NHSN, which is a different level than what was previously needed. So additional work needs to be done to gain this access, which is why they gave us until the end of May.
Okay.
Okay, so with that, that does appear to be our last question. So if you do think of anything after the webinar has concluded, you do see the emails up on the screen right now. You can email Safe and Calm, Dalton, or Deanna at leadingagemi.org, and we will make sure to get those questions answered for you. Just a quick reminder that we are going to every other week. So our next webinar will be scheduled for Wednesday, May 19th at this time. So 2 weeks from today, again at 10 a.m. And so with that, we would like to just thank Deanna as always, and we would also like to thank the 96 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. With that, I hope everyone has a great remainder of their Wednesday, and we will see you in a couple weeks. Thank you and have a great day.
Bye, everyone.